Also did critical care while I was in ambulance services. So I'm fairly versed in circulation shock and resuscitation. If I'm talking too fast for you guys, let me know. Sometimes I do speak a little fast and it might not be too clear. So today's subject is going to be over circulation shock and resuscitation. If you have any questions, please feel free to stop and raise your hand or just stop me and say that you have a question about anything that I'm saying or if it's any clearer. So today we're going to talk about circulation, do a brief uh, review over anatomy, physiology of the circulation system. We're going to do a assessment and reassessment of vital signs. We're going to talk about bleeding, how to control bleeding, and when to initiate IVs, IV fluids, and the parameters for doing so with those. Can everyone see the slideshow okay?
Yeah. Yes.
Okay. So circulation involves a lot of things, and there's certain things that we want to check for when we are assessing circulation. So we, in battlefield, we're taught to assess for shock. The first thing that we want to check is the pulse, and we want to check it on the radius or the radial pulse. We check the radial pulse because it's an indicator, and it lets us know if the individual is going into shock, what their minimum blood pressure would be. We go by the 60, 70, 80, 90 rule. So 60 would be your femoral, 70 your carotid, 80 is going to be your radial, and 90 is going to be your pedal pulses. For us, radial and carotid, those are the easiest ones for us to assess. And the radial one is going to let us know what our blood pressure is at a minimum if we don't have any of the equipment to assess. Along with that, we want to assess the rate, rhythm, and quality. We want to see if it's fast, if the heart is pumping fast. If it's erratic, it might have some other things that's going on with it. If the pulse is weak, it might be an indication that the patient is hypovolemic and might be going into shock. So we check all of those things. If we can't get anything on the radio, then we'll go to the carotid and check the pulse there. And as long as with everything, we want to trend our vitals. So every time that we assess something, we want to write it down so we can trend it and make sure that everything is going in the right manner. And we can see if there's any deviations to the pulse as we're treating the patient. If the pulse is going up or rate is going up, the rhythm is going up, or if it's going down, it's going to give us some indications of what might be going on with the patient. So a couple of other things we want to check. We always check the level of consciousness with the patient, and we do that by doing the AFPU, alert, visual, painful, or unresponsive. If they're alert, A&O times, I use A&O times 3. Some other people might use A&O times 4. That's just asking them certain questions and trying to gauge if they're able to answer it correctly. Usually we do date, time, location, month, or you can ask them who. In the States, we might ask who the president is because usually everyone knows who the president is. That's a way of gauging it. I wouldn't do too much now. Some of us don't really like our president, so that's not a good thing to ask right now. The heart rate, normal heart rate is between 60 and 100. You gotta, in some cases, heart rate might be lower depending on the patient and their physical. Their actually heart rate. Some people run low heart rate, so it's hard to whether that is okay, there we go. Yep, so heart rate is other things that you want to check. Heart rate is the basic, but you want to actually look at your patient. You can't base everything off of one single vital sign. So you want to look at your patient to make sure that what you're assessing is actually what you're assessing. Heart rate, we go off of carotid radial femoral. Not really too much femoral. Is more for us is carotid and radial. Those are the two most accessible points for checking your heart rate. The blood pressure, our normal is systolic, diastolic, 140 and 60 to 90. You want to make sure that those are strong and bounding, or if they're weak and absent, is the indication that the patient might be going into shock and they might need resuscitative fluids. Respirations, respirations are normally between 12 and 20. It might increase to compensate for shock, or it might decrease. So we want to pay attention to all of those while we're doing trending vital signs. So pelvic binders. For us, when we teach TCCC, the pelvic binder is like number one on the list now because of internal hemorrhaging. If you break your hip, you can bleed out from breaking your hip. It's a large bone, it holds a lot of blood. So we tend to put on pelvic binders if the hip is unstable, if they suffer a traumatic injury where both of their lower legs are amputated, it'll be an indication to put on the pelvic binder. You can use the pelvic binders that companies make. You can create your own pelvic binder, how we teach it here, because they don't have any other commercial devices here. You can take a sheet to make a pelvic binder, the patient's shirt, your shirt, anything that you can do to bind that pelvic together and keep it from moving. The goal is just to keep the pelvic from moving, and it's going to help control the bleeding. When you do that, you want to be able to, you want to check your pulses, radial and carotid pulses. If they have lower limbs, you want to check your pedal pulses, make sure that those are there. You want to look for your junctional wounds. For anyone who don't know what junctional wounds, we go by the NAG system. Your junctional wounds will be your neck area, armpits, and groin. It's those deep wounds that you can access with the tourniquets. So junctional wounds, we would use uh, pressure dressings to try to control the bleeding. We can use they have a device out there called an X-Stat. The X-Stat is basically just a bunch of mini sponges and a syringe that you can insert into that tract. And when you insert it and press it, the sponges, once they make contact with the blood, they absorb the blood and they expand. Once they expand, it's supposed to cut off the bleeding, and that should save the patient. And then we're going to talk about the IV axis of when we want to give a patient an IV, if we want to give them fluids, or if we just want to do a stat lock in case they might need fluids later or they might need medication later. It's important to understand that not all patients are going to need IV access. It's nice to have, especially if you're unsure of what's going to happen, or if you're unsure of your environment, you might be there for a while. It's nice to be able to go ahead and just get that IV access whenever you can. That way, when it's time, you're not in the rush to do it, and it might be difficult to get. But if they're not suffering from a major wound, if they're not going to require surgery, they don't need any medication, or they don't need IV fluids, it's not recommended to give patients IV access. Any questions so far? I'm gonna take that as a no. So with the IV access, we want to do large bore IV accesses. Stop laughing, Mario. We want to do large bore IV access. You don't want to put it on the affected arm. You want to make sure that it's on the arm that's not affected. We do arms. Some of the paramedics, we do EJs. That's actually kind of easier for us to do. It's bigger, it's more accessible. We don't have to worry about it being cut off by tourniquets if they have to go on. Or we can do IO access, intraosseous access, and that's usually done with the easy IO and the femur. Or if they have the fast IO, it's a sternum. It just depends on what your company has, what your hospital has, and what access that you can get with those. So we already went over pelvic fractures. The cases of where you suspect a pelvic fracture, you want to put on an improvised pelvic binder or just a pelvic binder. It's going to hold the hips together. You want to put it around the greater trochanter area. Blah 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 blah. Can't even talk straight. And the pubis symphysis. James, help me out. Pubis symphysis. Okay, James not gonna help me out. So
Pubic
basically,
synthesis.
there you go. You want to find the area and you want to put the pelvic binder around that area. And that's the spot that's going to hold it together. You do that for major limb amputations or near amputations. If they're involved in blast, missing both legs, first thing that we're supposed to think about once we get down to a circulation phase is going to be a pelvic binder to help control the bleeding, to stop the bleeding, and hopefully to save that patient's life. So another thing, if the patient is in shock and they're suspected of having these, then we want to put on a pelvic binder as well. So best tactical indicators of shock. I mentioned it earlier. Best tactical indicators of shock for us is decreased state of consciousness. This is where it's important that we actually trend our vital signs. We trend what's going on with our patients. We talk to the patient. You want to be able to have a conversation with them while you're doing it so you can gauge whether they are starting to decrease on that consciousness level. And it also helps to calm them down in the process. And that's a good way to notice if something is changing with your patient. If you don't talk to your patient, you won't know what's going on. You can't just base everything off of the vital signs. Treating the patient is more than treating vital signs or treating symptoms. It's treating the whole patient. So knowing what the state of consciousness is going to be helpful if that patient starts to deteriorate. That way you can tell, okay, well, he was just talking to me a minute ago. Now he's talking, but he's not making too much sense, or he's getting very slow. And words are just not coming out right. They might be slurring. That's one of the indications for the patient going into shock. You want to check the skin, pale, cool, or clammy. The patient is suffering from pale, cool, and clammy skin is an indication for shock. We want to pre-treat shock and hypothermia. So another thing that we want to do, we want to make sure that our patient stays warm. When you bleed out or you get cold, your blood doesn't coagulate well. So keeping that patient warm, keeping them calm is going to help them once they start going into those phases of shock. And then you want to check your radial pulse and your carotid pulse. Radial pulse should be a minimum of 80. That's going to let you know if the patient has a decent blood pressure. If that patient loses that radial pulse and they have a carotid pulse, that's going to be one of your main indicators that that patient is going into shock. And that patient is going to need some type of IV fluids to bring them out of that shock before they get into an irreversible shock. We're going to talk about the shock once we get down into that section. So we're going to go in between the hypovolemic, the neurogenic shock, the irreversible shock, compensated shock, decompensated shock. We'll talk briefly about a few of those. So pulses in our body. Body has arteries, it has veins, capillaries, all that good stuff. We know where blood comes from, how it rotates through the body, how it gets oxygenated, how it goes through the chambers of heart. We worry about the pulses with the radial pulses, the carotid pulses, and the femoral pulses. Sometimes we can check the pedal pulses. I don't too much like checking popliteal pulses because it's kind of difficult to find. And if I'm in a situation where it's an emergency, I'm not trying to waste time trying to find a popliteal pulse. If I can find that a radial pulse or the carotid pulse and I know the blood is circulating, then I know that I'm good. So arteries carry blood to the tissue, veins carries blood to the heart. Heart contraction can be felt as a pulse that's going through your 60 through 100 for your range. Any question on pulses?
Nope. Nope.
I wasn't gonna y'all to answer because y'all be taking too long anyway. I was just gonna keep on talking. But the transitions was kind of slow, so it gives you a good 5 seconds for someone to ask a question if they need to ask a question. So priorities during circulation. As we mentioned before, priority number one, if you suspect a pelvic fracture, W amputation of the lower extremities, number one priority is to apply a pelvic binder. Second priority is exposing the wound and dressing the wound. If they have a tourniquet on and they're not in shock, then it's controlling that wound in a manner that's not requiring a tourniquet. And for that, it's going to be pressure dressings or hemostatic dressings or junctionals. So we teach tourniquet conversions. A tourniquet conversion is taking what we call a hasty tourniquet. The hasty tourniquet is what we put on the top of the clothing and we put it high and tight away from the wound, and that is just to stop the bleeding initially. We don't want to leave the hasty tourniquet on because you run the risk of losing that limb if it's on too long. It's effective, but it's not doing what it needs to do as far as treating that wound. We want to save as much as the limb as humanly possible. So when we can and everything is safe, we want to try to do a tourniquet conversion to move that hasty tourniquet down to a deliberate tourniquet, which is going to be about 3 inches above the wound or 3 to 5 centimeters. I forgot the conversion part of it. I think it's 35. 2 inches above the wound, 35 centimeters above the wound, not on the joints. Or if we can control that bleeding using a pressure dressing, that's another thing that we want to use. So pressure dressing is just taking the Curlix or the gauze or any type of special gauze that they have that may have hemostatic agents in it that stops the bleeding and packing it into that wound to stop that bleeding, create a clot. And then once we get that and we leave about 2 inches of material over to create a nice little pressure point. So when we apply the actual ACE bandage or the emergency bandage, we can wrap it around that ball and it's going to create additional pressure to help stop the bleeding of that wound. But before we put on that elastic bandage or the emergency bandage, we want to hold pressure on that wound for, if you have a hemostatic agent, you need to hold it for about 3 minutes. If we don't have a hemostatic agent, can anyone tell me how long we want to hold pressure on that wound?
10 minutes.
There we go, Jake. 2 minutes. It can't be just James and Jake answering questions. Everybody else gonna have to answer questions, or I'm just gonna stop talking. But yeah, we want to hold for hemostatic agent. We want to hold it for 3 minutes. Non-hemostatic agent, if it's just we want to hold it for 10 minutes. And while you're holding it, you want to look at it to make sure that the blood is not seeping through. If the blood is seeping through, then that means we need to take that dressing off, apply a new dressing, and do it all over again. Once we have that bleeding controlled and we see that it's not seeping through, the gauze is clean, that's when we're going to apply our elastic bandage or emergency bandage. That way it's going to hold that dressing in place. It's going to free up your hands to do everything else that you need to do to help save that patient's life or limb. While we're doing that, you want to slowly loosen the tourniquet. You don't want to just release everything. Slowly loosen the tourniquet. So if it does start bleeding and it's very pronounced, we can tighten that tourniquet back up and we'll just leave it at that. Let that go. And there was something else I wanted to say. Oh, tourniquet conversions you want to do as quickly as possible, and there is a time limit. If their time limit is over 6 minutes or over 6 hours, we're not going to do a tourniquet conversion. Once that tourniquet has been on for 6 hours, that's it on our end. We let the hospital worry about that because you're going to need special equipment to test the lactic acid buildup, everything that's going on. Once you cut off circulation, you're depriving that limb of the oxygen and the nutrients that it needs to survive. So it's basically deteriorating the whole time that the blood circulation is not getting to it. If we release that after a certain amount of time or after that 6 hour mark, we have the potential to causing a lot of harm to the patient. And we have the potential of killing that patient from all of those toxins going back into the circulatory system, affecting the heart, affecting the lungs. So respiratory failure and respiratory arrest. The respiratory system and circulation system basically are hand in hand. Without circulation, respiratory is not going to do any good for the body. You need blood for the respiratory system to work at its maximum. We need oxygen to circulate through the body, circulate to the brain, circulate to all the organs, all the parts of the body. If we don't have any blood, then us breathing for the patient, helping them out of respiratory arrest is not going to do any good for the patient. So the definition of respiratory failure is just the reduction of breathing to the point where oxygen is not sufficient to support life. Same thing, respirations have basically stopped, and it's going to lead to cardiac arrest if it's not treated. But respiratory and circulation are hand in hand. So a couple of general reasons for heart stopping or stop beating, or you can have sudden death or heart disease. In the field, we can't determine if the patient have heart disease unless they tell us, hey, I have a heart problem, I have a heart block, something might go wrong, I have AFib, I have a pacemaker, something like that. We won't be able to tell in the field unless we have equipment to actually uh, look at it. If we have a defibrillator or actual life pack, we can put on there and see if they have a pacemaker, if it's actually work, the pacemaker is actually working, if it has the spikes. If the breathing stop, especially in infants and children, then eventually your heart is going to stop. And then medical emergencies for trauma is another general reason for heart stop. Chest compressions, BLS. For chest compressions, we want to do very effective compressions. It's going to be what's I think I forgot the depth that we want to go. For me, in the ICU, our saying was, if I don't break a rib, I'm not doing an effective chest compression. I'm not just going to sit there and pump on your chest and move it maybe a half inch or maybe an inch. I want to put enough effort into it to where I'm pushing enough pressure on your heart that it's going to circulate the blood through your body so it gets to your organs. So your compressions don't need to be shallow. They need to be nice, even all the way around. Slow compression rate, we sing a song while we're doing it. Once you get to a point where you've been doing it for years, it's pretty much natural. You don't have to sing a song. You don't have to count. You pretty much know what rate you're going to be doing on your chest compressions. In the hospital, if you have a life pack, they actually have a little monotone sound that you could put on to make sure your chest compressions are being delivered at the right amount of time, and it helps to keep you somewhat fresh, so you're not exerting too much effort or you're not pushing too hard, pushing too fast. So another factor that decreases effectiveness, submaximum recoil. You're doing compressions and you're not actually letting the chest rise before you press it back down. So you want to push it down, let it rise all the way back up, and then push it down again. You don't want to stop it in the midpoint. That's not going to give enough compression to push blood throughout the body or push blood through the organs. So you want to push, let it recoil, push again. And then frequent interruptions, we do CPR and compressions in cycles. We do it in cycles so that we can check the pulse to make sure we can shock the patient if need be. And we do it in cycles to keep everybody fresh. If we have enough people, you might do 2 or 3 cycles before someone comes in and say, hey, I'm gonna relieve you for a few. They're gonna do a few cycles. And then after that, if the patient is still needing CPR, it just keeps rotating like that. I know one time when I was working in the ER, I think we did CPR for about an hour and 15 minutes on one guy. And we would get him back, but probably about 5 minutes after we get him back, we lose him again. So it was a long hour and 15 minutes of us doing CPR amongst other things that the doctor was doing, trying to stabilize that patient and get him back. And then we're going to talk about shock. So shock is the poor perfusion, results from inadequate delivery of oxygenated blood to the body tissues. There's different types of shock that we have from, oh crap, my battery's running low. Cardiogenic shock, we have that, neurogenic shock, hypovolemic shock. It's a bunch of different shocks that we go through. We have different phases of shocks. For us, we worry about right now is compensated, decompensated, irreversible shock, hypovolemic shock. Those are what we can treat right now in the field. Hold on, as I walk, I'm just going to plug in my computer. So, can anyone give me a definition of perfusion? So I don't have to read it off the screen. Not Jake, not James. Anyone going once? Anyone going twice? Y'all really gonna make me read?
Are we supposed to read? Because we are not doctors.
Is the passage of blood. Are you getting me?
Go ahead. I got you.
Hello?
Mm-hmm.
Is the passage of blood and oxygen and other essential nutrients to the body's cells.
Basically, I don't know who said that we're not doctors part. I'm not a doctor either. But basically what she said, perfusion, your heart is a pump. It's a very efficient pump. It's probably one of the most efficient pumps that we know about. Its purpose is to perfuse or supply the body with blood and oxygen. So that's basically all perfusion is. It's your heart pumping to give your body the blood and oxygen that it needs to give to the cells and to all the areas of your body, your organs, to make sure that everything is oxygenated. It also takes the waste from those areas, your carbon dioxide, and brings it back into the lungs so they can get oxygenated again, remove all the waste, goes back out, does the same thing all over again. Very, very efficient pump. That's all perfusion is. It's just delivering blood and oxygen to all the essential parts of the body. Shock is a state of hypoperfusion, or inadequate perfusion. So your body reacts in a certain way when it's injured or if it doesn't have anything. If we don't have enough blood, we go into hypovolemic shock. So your body is going to try to compensate for not having enough blood as much as possible. And that's going to be your compensated shock, be your heart rate, your respiration rate. All of those things change when we go into, or if we're in compensated shock and we start to go into decompensated shock. Decompensated shock is just saying, okay, look, my body has been fighting this for a minute. We need to do something to fix this now. If we don't do something to fix this, I'm already decompensated, but it's going to get to the point where I'm not going to be able to do anything. And that's going to put us into what we call irreversible shock. Irreversible shock is exactly what it sounds like. It's a shock that your body has fought for so long. It tried for so long. It compensated. It decompensated. Now it's at the point where, you know what? I'm just done. It's nothing else that I can do to help. You ignored me for this long, and I'm just going to give up now. So those are the three phases of shock. We have compensated, decompensated, and irreversible. So blood value by size for adults, males, females, we usually hold about 4 to 5 liters of blood in our body. Normally we can lose for adults 1.5 liters. Everything's fine. It's not going to kill you. For children, they have about 2.4 liters of blood in their body, and infants have about 0.8 liters. The volume of your blood is regulated by your kidneys. And my favorite, so when I worked in ICU, I had to do a whole lot of telemetry and a whole lot of cardiac stuff. So me and the heart were like best friends. I was able to teach. I did a paramedic class in Fayetteville with a couple of other Air Force medics, and our instructor wasn't that well versed in the cardiac function and anatomy and physiology of the heart. We're not going to go through too much of anything in here. It's just giving us pretty much the basics of it. Your heart is consistent of 4 chambers. You got your atrium and your ventricles, your right side and your left side. Right side takes all the blood and pumps it down from the right atrium to the right ventricle into your lungs, comes back, goes into your left atrium and your left ventricle, and it goes out into your body. 3 pacemakers, or 3 natural pacemakers for the heart. You have your AV node, your SA node, and your Purkinje fibers, or bundle of his. So, and all of those are just in the normal. It's going to regulate what your heart rate is. The AV, SA, or your AV node, or your normal, and that's going to be your 60 to 100. Then your SA nodes, it's like your backup pacemaker. And then your Purkinje fibers, or your bundle of his, that's going to be your last pacemaker. That's pretty much the fail-safe. It's going to try its hardest to keep you perfused and oxygenated, or your blood, but it can only do so much because it's not actually allowing your heart to function in the way that it's supposed to function. And then you have your blood goes from your arteries to your veins, all the rest of your body. Anyone needs to go through a good detail on the anatomy and physiology of the heart and blood vessels, because I can talk about that all day. I love the heart. It's a beautiful thing. 5. Take that as a note. It's the portion of the cardiovascular system that carries blood between the heart and the lungs. Just like I mentioned in the last side, you have your right side and your left side. Right side is taking the blood, pumping it down into the right atrium, down into the right ventricle, then it's going into your lungs, gets oxygenated, comes out of your lungs, goes into the left side, goes in your left atrium, down to your left ventricle, goes out, oxygenates the rest of your body. And then the heart has its own, supply of, or the heart has its own way of perfusing itself to make sure that it gets the nutrients that it needs. It's your coronary arteries and all that good stuff. So back to shock, the disruptions that can cause shock. You have inadequate fluid, blood water loss. That's going to be your hypovolemic shock. The failing pump or failing heart, Maybe a cardiogenic shock that comes along with a whole bunch of other symptoms that we have to go through, a whole bunch of other injuries. Right now, we're worried about hypovolemic shock. There can be a disease or injury to the heart or conduction system, damage to the cardiac muscle, leaky or dilated container vessels, loss of nervous control. That can be a neurogenic shock, severe allergic reactions. That's your anaphylactic shock. Massive infection is going to be your septic shock, and then hypothermia. And all of those can it will affect your body. So compensated shock. As I mentioned earlier, the compensated shock is, okay, so we might have lost some blood, but your body is going to do everything that it can to adjust to compensate for that blood loss. You're not likely to die from compensated shock. Your body can handle losing about 15% of the blood loss, or about 1.5 liters. After that is when your body starts to go into trouble, and it might go into decompensated shock. Then you have your irreversible shock, which is the rapid deterioration of the cardiovascular system. It means everything is shutting down. So when your body goes into shock, it tries to pull the blood away from the peripheral area. So it takes everything from your limbs and it wants to bring everything, it shunts everything and it brings it down to your vital organs, your lungs, your brain, your trunk area. It wants to perfuse the organs first before it'll perfuse your limbs. And then irreversible shock, cell death begins, which will progress over the severity or several days. So if you stay in an irreversible shock, which you won't stay in an irreversible shock long if it's not treated aggressively. It's just saying that cell death will occur in the rest of your body. So signs and symptoms of irreversible shock. You have a marked decrease in level of responsiveness. This is why we say we have to monitor the patient's vital signs. We have to trend the patient's vital signs, need to talk to the patient, make sure that we are able to understand what changes may have happened or what changes are happening with that patient. They lose a level of consciousness, or they may be alert times 3. They might decrease to alert times 2, or decrease to alert times 1. That's letting you know that the body is going into shock. Something is going wrong with the patient. You can have a decreased respiratory rate or a profound respiratory rate. The patient might start breathing faster, start breathing slower. You have a decrease in your pulse rate from not enough blood getting to the heart. And the patient's feeling of impending doom. If you haven't dealt with the patient that had that feeling before, it's hard to explain, but it's very easy to recognize. They might tell you, I don't feel like I'm gonna make it, or I feel like something is like seriously wrong. When I was doing paramedic school, we actually had a call, went out to a patient, and he was complaining of chest pain. And we did the check, we did our EKGs, we did everything that we could do at that location. And talking to the patient, we explained everything to him, like, hey, you might want to go get this checked out. And he refused to go get checked out. But as we were leaving, he was saying that he wasn't feeling too good and he just felt like everything was all going bad. So we stayed probably for about another 10, 15 minutes, tried to convince him, did another EKG. It didn't show much on the EKG, not enough to where we could convince him to go. But as we left, probably 20 minutes later, the call came back and there was another crew that went out there and the guy had a massive heart attack. So your body knows when something is wrong. It knows when it might be the end of its run. If the patient has that feeling of, yes, I think something's wrong, I think I might want to die, we need to take that seriously. want to get that patient to the ambulance or get that patient to the hospital as quickly as possible. So the providers with higher level of care, better equipment can treat that patient. So the shock due to fluid losses, we have a hypovolemic shock, that's just low blood volume. Cardiogenic shock is the heart failure caused by profound failure of the heart, severe MI. That's what the guy that I was just talking about had. He had a severe MI, led to his death. Severe heart failure or trauma to the heart. You have a good peripheral resistance and adequate blood volume, but the heart is not pumping properly. So you can not have any injuries to where you're bleeding out, but with cardiogenic shock, if something is wrong with your heart and it's not operating correctly, then you can go on a cardiogenic shock or pump failure. Neurogenic shock is the nervous system is no longer able to control how your blood vessels dilate and constrict. That can lead to hypovolemia as well. If you dilate and you have no control of it, that means your heart can be pumping, but it's just pumping through an open hose. So it's pushing blood out, but it's pushing it out to a point where it's not perfusing pretty much anything. It's just going out. Your blood vessels constrict and dilate so that perfusion is adequate throughout your whole body. Is no longer able to control the diameter of blood vessels, leading to hypovolemia, usually from severe brain or CNS injury. There's not much that we can do for patients suffering from neurogenic shock, especially if we're in the field or we're in the back of an ambulance. Best thing that we can do, or the most prudent thing that we can do, is get them to a higher echelon of care as quickly as possible. And then septic shock is caused by an infection, which causes massive vasodilation. Blood plasma is lost through the vessel walls, results in hypovolemia. Patients going into septic shock, they might have suffered an injury or an infection, internal bleeding. If it's not caught, it can lead to septic shock. This doesn't happen as quickly as hypovolemic shock, but we still need to be mindful about what's going on with the patient as far as the injuries. That could lead to septic shock or sepsis. The definitive care for septic shock is going to be the hospital. There's not much that we can do to treat septic shock. And then pediatrics. Oh God. I'm not a big fan of dealing with pediatrics. Kids scare me. The reason I say they scare me, kids compensate very, very, very well until they stop compensating. Once they stop compensating, it is a struggle, or it's hell trying to get them back when they get to that stage. So for pediatrics, we want to be extremely mindful of what's going on with that patient, because while they're compensating, you might think that everything is good, but with pediatrics, it can change in a second, and everything can just start going bad. And once they start going bad, it is going to be a struggle trying to get that patient back. So common causes of shock with pediatrics, it could be trauma, fluid loss, if they're suffering from dehydration and diarrhea, vomiting, that could be another cause of shock for them. But that we would want to get them fluids as much as possible. If they are able to tolerate fluids, PO, we can give them Pedialyte. It's going to help provide some of the electrolytes back into their system if we have it, or IV fluids is what we have in the rigs. Infection, anaphylaxis. Anaphylaxis, we can treat that with epinephrine. Congenital heart disease and chest wall injuries, another common causes of shock. Geriatrics, the body system changes with the geriatrics. You start losing muscle tone, your body's not able to compensate as well. They get cold easily because the muscles start to deteriorate, and the body's not able to shiver or create or generate heat the way that it's supposed to generate heat. So with them, just like with children, we want to monitor their vital signs, make sure that we keeping a good eye on it. We want to monitor their airway, their breathing, the circulation. We want to get you a good baseline of all three so that you know if there's going to be any changes. And then the skin, like I said, it's a little bit more difficult for them to generate heat. They might be cool or cold most of the time. Skin might not be as firm, or it might not have the elasticity that our skin has. Medications that may mask shock symptoms, beta blockers. The beta blockers prevent increase in heart rate. So decompensation will be more and it will happen quickly because the heart rate is not going to increase to try to compensate for it. It's not going to be able to constrict those blood vessels. That's why we try to do a good sample history. That way we know what that patient is suffering from if they're able to talk to us. If they're not able to talk to us, we'll talk to their family and friends to see if they have any idea of what the patient might be taking, what medications they might be taking, if they have any kind of heart disease, congenital heart disease, if they have a pacemaker. Those are the things that we try to get from those. And beta blockers is one of those. We want to make sure that we ask for that so we know, okay, well, heart rate's not increasing, but if we're looking at all the other signs, we can see that this patient might be going in the shock. But that's why we can't just look at one thing. We have to look at the whole body, the whole patient to make sure that everything is lining up. We can't just rely on one vital sign to make a determination. And with us, they taught us to have three differential diagnosis. So for me, whenever I get a call, after I get the basics of it, I'm thinking the worst thing imaginable in my head based off of what I'm getting from dispatch. That way I'm preparing myself to, okay, this is what could happen. I hope for the best, but I prepare for the worst. When you approach situations like that, it allows you to have those three different differential diagnoses. It allows you to expound on your thinking. So it might not be this one thing. It could be something that is very similar to it and is having the same symptoms of it, but you have to allow yourself to think outside of just those basic things. That's what the differential diagnoses are. It's just putting together a list of things that may be wrong with the patient. And as you're assessing that patient, you're knocking off those signs and symptoms. You're doing check marks. Okay, so this goes with this goes with this doesn't go with this doesn't go with that. So it has to be, or it's probably going to be this one. That way it allows you better to treat your patient. Tension, here we use crystalloids or colloids. So normal saline is the most common fluid that we use. Normal saline lactated ringers usually come in 1,000 milliliter bags. Depending on the injury, depending on the patient, it could be just giving them fluids, a little bit of normal saline if they're suffering from dehydration or hypovolemic with no external injuries or no traumatic injuries. They might just be dehydrated, and giving them fluids is what's going to help them the most. Hextan is some medication that expands blood volume. It used to be that we could only give 1,000 milliliters of Hextan, and we use Hextan for traumatic injury. So if the patient is suffering massive blood loss from, let's say, an amputation to one of the extremities, and they don't have a blood pressure at the radial, but they have one at the carotid, then we want to give them Hextan to expand the blood volume and get that pulse back. We give it at 500 milliliter boluses. And it used to be that we could only give 1,000 of Hextan as the maximum dose, but now we can actually give more Hextan if needed so that we can get that blood pressure and that heart rate back up to where it's supposed to be. Any question on retention of fluids?
Yes, Lim.
I don't know what that was.
Just please mute
It sounded like
the laptop.
he DJing.
That's that's weird and crazy. Yeah, so Amoro has a question. Yeah, that if you have a patient in septic shock and is experiencing hypoglycemia, and the patient has started on an insulin drip, what would be a blood glucose goal for this patient?
Oh Lord, you were actually about to make me get into my paramedic medicine type stuff now. Okay, so hypoglycemic shock, hyperglycemic shock. We're gonna need a glucometer to tell if the patient is suffering from low blood sugar, hypoglycemia. Yeah, caught me off guard. For that, we're treating the patient. Their patient is gonna need not insulin. Hypo, you need actual glucose. You need sugar into your body. So treating hypoglycemia and treating septic shock, it's kind of two separate things. Hypoglycemia is easier to treat because basically if we can give that patient the glucose that it needs, that's going to fix that at the moment till we can get them to a higher level of care. Treating someone for septic shock is going to require a lot more of interventions. You're going to need antibiotics. You're going to need fluids. You're going to need, depending on how bad the patient is, patient might have to get intubated. It's septic shock is it's a course all of on its own, trying to treat that. We don't treat septic shock in the field. It's not much that we can do to treat septic shock in the field. Hypoglycemia, that's easy. We find out what the blood sugar is. If it's low, we give them glucose. If it's high, I don't know how many people carry insulin on the truck. I know for us, back when I was actually working, we didn't carry insulin on the truck because we would just take them to the hospital and let the doctors deal with it the way they wanted to deal with it. Some of them might have to go on a sliding scale. It's different types of hyperglycemia. You can have DKA, you can have HHNS. So treating hypoglycemia and treating septic shock are two different things. Hypoglycemia we can treat with glucose. Septic shock is going to be medication, antibiotics, fluids, and that's going to be treated. Why is it popping up on the screen? Jake, you got too much time on.
No, that's on you, bro.
Like, what in the world is it?
Yeah.
So, any other questions on hypoglycemia, hyperglycemia, septic shock? I'm sorry, I can't really explain it any other way because it's two different things, but just the way that we treat it, one is glucose, the other is going to be antibiotics, fluids, and a whole bunch of other things that I'm not qualified to even try to prescribe or talk about. I just know the basics of it.
Hey, Liam, this is James. I think it's probably important too, just let them know there's a difference between like long-term care in an ICU versus like emergency medicine. As far as like treatment protocols.
There is a difference in treatment protocols, difference between where you are at, what your company is, and what they say that we can do or what they say that you can do. So how we treat some things in the U.S. is not going to be the same way that other people treat things in the other countries around the world. So protocols is basically your MD or your medical director has a set list of ways that we treat the different types of injuries that we encounter on a day-to-day basis. For us, we get those protocols and we learn those protocols, because when you're in an emergency, you don't have time to pull out the book and look through all the protocols to try to figure out what's the best thing to do. So we learn the protocols as pretty much second nature. That way, when we see something, we automatically know what's going on and how we are allowed to treat it. Certain things that we can do. Example, for us, if we have patients with airway injuries and we can't get or out here, I guess a King LTD or a supraglottic airway in, we are allowed to actually do surgical crikes. Over here in Saudi, they're not allowed to do surgical crikes. Pretty much if they can't get a King LTD in, that's pretty much it for them. They can do OPA, NPA, King LTD. I'm pretty sure the paramedics may be able to do endotracheal intubations. I haven't worked with many of them, and I don't know what they do in the field, but protocols allows us, or it gives us the discipline of what we're allowed to do when we're treating patients. And pretty much everyone has those protocols based off of what the medical director has as appropriate for that company or that hospital. Good, James?
I think that
Answer.
no, that I think that hit the nail on the head. I mean, it's just in emergency medicine too. I mean, you're just going to treat patients differently. You're going to treat for life threats versus like, in the example they were talking about was like, you know, treating a patient for hypoglycemia while they're on a insulin drip. More likely, we will never engage a patient unless we're doing a patient transfer on an ambulance that's on an insulin drip, especially for sepsis. I mean, sepsis is like for me to treat sepsis in the field is kind of like what Liam was saying. It's definitely something that I would not worry about at the moment because we don't have a lab. You know, we don't know what type of septic shock, you know, what type of bacteria is going on with that patient. I mean, at best, we could do a broad spectrum antibiotic, but I mean, really, that's something that MD should, you know, that's something that they should, you know, they're trained to do. They've had more training on it, and they have more resources to be able to, you know, implement a treatment plan for it. But yeah, great job, Liam.
Thank you, James. Yeah, what he was saying with septic shock in the field and hypoglycemia, we're going to treat hypoglycemia. That's what we're going to treat. We're going to get that under control. That septic shock part, I'm leaving that up to the MD. Once I get the hypoglycemia under control, I can try to treat the symptoms of the septic shock. If the patient might be needing IV fluids, yes, we can try to, or we can give IV fluids, but as far as definitive care or even trying to put a dent in the septic shock, they need to be in the hospital for that. We have no type of equipment in the field to treat septic shock. Back to Hexten and the Hexten protocol. For Hexten, it's a volume expander, so we give it to help increase the blood volume. For the procedure, if we have IV access, then we would give 500 milliliters of Hexten. We would reassess the vital signs. I'm going to ask Jake how long after the first dose of Hexten before we give the second one. 30 minutes. Jake's not answering. So we give Hexten, wait 30 minutes, or we assess the vital signs, wait 30 minutes, reassess the vital signs. For stable patients, we assess the vital signs every 15 minutes. Unstable patients, we assess the vital signs every 5 minutes. If we give the Hextan 500 milliliters and we determine that the patient requires more, we would give another 500 milliliters of Hextan. It's a bolus unit. We're trying to titrate usage of it. You give 500 milliliters of Hextan. You assess vital signs. If the vital signs are stable, we disconnect Hextan. If the signs are not stable after 30 minutes, we give another 500 milliliters. So on and so forth. We get the blood pressure 90 milliliters of any blood pressure machine, then we would just check the radio pulse to see if it's bounding or if it's palpable. All right. And if it's not, then we give another 30 or another 500. So a couple of things. We already mentioned this several times during the presentation for IVs. Not all casualties need IVs. If the patient does not need it, we do not give it. We don't want to waste our supplies on the patient, and we don't want to waste time doing something that doesn't need to be done. When we do, we want to maintain a systolic blood pressure of 80 millimeters of mercury. That means checking the radial pulse if we don't have any blood pressure cuffs. If we do, then we'll just check it normally. We want to resuscitate the patient until it's normal palpable radial pulse. So we want it to be nice, strong pulse that we can feel without trying to search for, closing our eyes and digging around the arm, trying to see if we can feel that pulse. So you want to be able to feel it. It should be normal. And tourniquet conversions. If the patient is in shock, we don't do tourniquet conversions. The reason we don't do that is the patient is in shock and you open up that tourniquet and you release all that blood, is just going to make that patient deteriorate and you're causing more problems than you really need to cause. So if the patient is in shock, we don't do tourniquet conversions. So down to the last slide. The only thing more tragic than a death is a death that could be prevented. Hypovolemic shock or massive hemorrhage is the #1 cause of death when we start talking about traumatic injuries. And it's very, very simple to fix. If we can apply tourniquet to stop the bleeding or apply emergency or pressure dressings to stop the bleeding, that's going to cut down on a whole list of problems that could come if we do not do that. Eventually, if we don't stop the patient from bleeding, the patient is going to die. If you get injured in your femoral artery, you can bleed out within 3 minutes. It's that big and blood travels that much through it. Other than that, all that I have from this presentation. Does anyone have any questions or comments about anything that we talked about over the last hour-ish? I take that as a no. So Jake, I'll turn it back over to you.
Outstanding. So could you add the sharing?
And the sharing. Sharing is caring, Jake.
I know. All right. Thank you so much, Mr. Limbrick. Yes, as you have heard, that's the circulation class. So the only thing more tragic than a death is a death that could have been prevented. So we're going to take these few minutes to take any questions. And so at least we have some people here. We have the team
Lord Bean.
who can react to your questions. Yeah, so if you have any questions, you can come online, you can talk, or you can type your question. Going once, going twice. All right, it seems today there's no questions. Yeah, I apologize for the earlier hiccup about my volume. Yeah, so now I'm using two devices. So I'm using the laptop and the phone at the same time. So thank you so much for your valuable ear and time. And we hope to move forward. So moving forward, next week, we're gonna have head, neck, and eye injuries. You know, that's one of the biggest injuries we encounter in our Kenyan roads. Yeah, so we're gonna cover head, neck, and eye injuries. Then after that, we're gonna go hypothermia and how to manage hypovolemia or hypovolemic shock or massive loss of blood on the site of the accident. Then we're gonna go to communication and documentation with the patient and how to report all the injuries that they have to the next echelon of care. Then we're gonna touch a little bit on medications that you can use safely in your home, or you can give anybody who is experiencing pain. And from there, then Dr. Jane Chege gonna come in and cover mental health, and she gonna deal in 3 areas. That's gonna be depression, stress, and suicide. Those gonna be her 3 main areas, because that's what affecting almost everybody in the world is depression, stress, and suicide rates are going up. So that's gonna be towards the end with Dr. Shege. Then we're gonna cover the last portion of evacuation, which we're gonna cover Medivac or Casivac, but on the ground we know we have ambulances, and so we're gonna see how we can evacuate and what we can use, the modes of transport we can use to transport our patients from X, which is, we call it X, but literally it means from the point of injury all the way to the hospital, what we can use to evacuate them and what we can be doing. And then to culminate the whole training, we're gonna do a complete patient assessment from when we started with massive hemorrhage or bleeding, then all the way to documentation and reporting. So we're gonna do the whole patient assessment, so at least you can see. So when you get to the site or when you get to the scene of the accident, what you need to do from A to Z, or from A to Z, what you're supposed to do to that patient. And then we're gonna show you, and also we're gonna discuss how or what you're supposed to do to hand over that patient to the next echelon of care. So when you get to the hospital, what you're supposed to do and what you're supposed to say. So that's gonna be our schedule for the next, like 1, 2, 3, 4, 5, 6, 7, about the next coming 7 weeks, inshallah, God willing. Yeah, so we hope, and then we hope to have a good time. So as usual, as Mr. Gideon will tell you, it's always good to submit your name, number, and email of a very good contact. So at least the team on the ground in Kenya can be able to get hold of you, because we told you we are not doing all this in vain. There's something coming, and we are looking for people to work with at the back end. So when we get on the ground, we want to get a talented pool of people, so who we can work with, or where we can be able to pull the people that might be needed to do A, B, C, D. So Mr. Gideon, you can tell them how they can get hold of you, which groups they can join,
Okay.
and the numbers they can use to reach you.
All right. Thank you, Jakes. I've already posted on the chat the link to the chat group. And just for your information, in case you need this presentation and the recording of this training, we post them every week on our WhatsApp chat group. So you can click that link to join. But also right now I'm posting our WhatsApp number. So in case you want to reach out to us through WhatsApp, the number you can send your question or feedback through, it's the one I posted now. Thank you very much, Jex. Someone is asking something. It's actually more of a feedback. It's Isa Premji. He's saying, amazing presentation, Jex. Why do we say patients instead of casualty?
Okay, so I'm just gonna, I saw Lim was, Mr. Lim was replying or acting on that question, but why we say patient instead of casualty is it's just for the psychological purposes. So when you're giving a report is a big word for you to say a casualty, because most of the people out there, they think a casualty is just somebody who maybe was involved in a car accident, something happened to him. But when you say a patient psychologically, it augurs well. So it's all about psychology. Psychology. So instead of calling a patient a casualty, just call them a patient. So at least you can culminate all groups or all the categories of those people, because not everybody is a casualty. Yeah. But it is not bad. But casualty mostly is trauma. But patient is not trauma. So it's all how you want to word it. But casualties, if you go to the hospitals, if you go to the casualty, you're gonna find all those people with trauma. But all of them, the bottom line, they are all patients. Okay. I hope that is clear, unless somebody else like Mr. Limbrick or James can chime in about
No,
casualty versus patient. You good?
no, I was trying to type that to Issa, but I had it set on you. That's why it went to you. But it was basically
Okay.
saying the same thing. It's a psychological thing.
Okay.
I mean, as far as my input, Jake, I mean, it's like you said, I mean, the terminology is pretty much universal. I just think a lot of people in the military or law enforcement or military-like jobs love to use casualty, you know, and then some people in the trauma world, they love to use casualty as well. But realistically, they're all patients. Once they fall up under your care as a medical provider, they become your patient. So, I mean, I think it's just what people like to use.
Awesome. Awesome. Yeah, thank you for that contribution. And thank you for that question. I think it came from Isa. Okay. All right. Do you have any questions? All right. Let me introduce you to Mrs. Mary Dongo. I don't know if she was ready for me to call her out. So at least you can know, instead of, in addition to Gideon, who else you can contact on the ground if you need anything on the ground, Kenya. Mrs. Mary Dongo.
All right, thank you, Jake. I think, well, I'm very much okay. We've talked with Gideon because on the ground, I think he will be more flexible. So really, if everybody gets hold of Gideon, I'm sure it'll get to me. So I think we are okay. Well, I think every evening we brief each other with Gideon. Sometimes I'll tell him to take over because I'm having a few other things. So yeah, we are good. And thank you, Rib, for that presentation. I think the reason why we didn't see a lot of responses is because it was more of medical, presentation. Most of the things I think those of us who are in the medical field would understand. But for then any other person, I think they were getting it as new. So, but it was good, very good indeed. Thank you.
Thank you.
Outstanding. So, anybody else? Okay. Hello? Somebody else is saying something? Okay, I think then we can call it a night. Yeah, so as I have given you the schedule, so that's the schedule for the next about 7 weeks or so. And we hope to see you here. So at least we can cover all these topics. And then maybe after that, then we're gonna start on something else because we want us to have a continuous cycle of activities. So thank you so much. Unless there's somebody else with any contribution, then from my side, I'll say asante sana, and may God bless you and your families. And I'll see you next Wednesday, same time, same place.
See y'all next week.
All right. Thank you so much. Shukran. Hey, Gideon. Do you want to mind stop the recording now?
Oh yeah, sure. I almost forgot. Thank you. Good night, guys.